Okay, Dr. Mehta, you can start now.
Yeah. So, Dr. Samir, that's your first case. You will keep the control or I'll keep?
No problem, I can request it, no problem.
Okay. So, whenever there's CT or MR, maybe you can request it.
Okay. So this is a male patient, 50 years old male patient presented with cough and hemoptysis. So this is a frontal chest radiograph of an adult patient presented with cough and hemoptysis. I can notice multiple abnormalities. First of all, there is in the right lower lung zone, there is an opacity with central areas of lucency suggesting cavitation. There is another smaller opacity seen adjacent to the. I'm sorry, there are some background noise. Excuse me, there are some background noise. Okay, so there are two opacities in the right lower lung zone. One of them is larger and showing central areas of lucency suggestive of breaking down, and there is another smaller area quite medially.
Sorry, Dr. Save, you can unmute yourself again.
Okay.
Dr. Same, can you hear us?
Yes, I hear you now.
Okay, yeah, you can start now.
Okay, there are another opacity seen at the left upper lung zone, and this one is slightly projected over the mediastinum. However, I can see clearly the aortic knuckle, and I can appreciate also the hilar vessels of the left upper lobar vessels. The lesion have a well-defined lateral margins and upper and inferior margins, suggesting that this lesion is most probably pulmonary in origin. Otherwise, I cannot appreciate any pneumothorax, lung, and the cardiac shadow is unremarkable, as well as the bony abnormalities. So, and this left upper lung zone lesion also shows central areas of lucences. So, in summary, we have multiple bilateral lesions, opacities with central lucences. So I'm thinking about multiple cavitating lesions, like could be multiple abscesses or multiple metastatic deposits. Other possibilities would include polyangiitis with granulomatosis. So I will convey my findings to the referring physician and compare with any previous examinations, and request further assessment by CT for further characterization of these lesions.
So what differentials you gave other than vaginous granulomatosis and
so I give them probably could be the metastatic deposits.
Which kind of metastasis can look like that?
With large size of metastasis could be renal origin.
So what is the characteristic of these metastases, you think? What kind of metastases are these?
You mean the terminology that we can use?
So you described that they have central lucency. So
yeah, cavitating metastasis. It could be cavitating metastasis.
From where do you think you can get
cavitating metastasis in adult male? So melanoma is a possibility. Renal cell carcinoma metastasis is another possibility. Carcinoma in the female. And thyroid malignancy is also another possibility.
Okay.
So this is what come to my mind right now.
Okay. And you mentioned about vaginous granulomatosis. So how do you diagnose that?
Vaginous granulomatosis will correlate with the clinical findings if the patient has chronic sinusitis. So this could be associated with the vaginous granulomatosis.
So how do you diagnose that finally? How is the conclusion made?
In this case will be correlated with the clinical findings of the patient. I would inquire if the patient has any primary malignancy, compare with the previous examinations. If no primary, non-primary malignancy, I will check with the patient clinical data if he has chronic sinusitis. This will raise the possibility of Wagner's granulomatosis.
Okay, we'll go to the next case. So this patient presented with shortness of breath. You have the control, right?
Yeah. So this is CT pulmonary angiography. Okay, so CT pulmonary angiography, I can just scrolling in the other way. Sorry. I think I changed the case by mistake.
Yeah, you changed the case. Yeah, you changed the case.
Maybe go here.
You can go to the previous one. Doesn't go from there. We can go from here. So I just leave the control. I think I'll change it.
I'm not controlling.
Okay. This one over the
Okay.
past, and actually this one is hiding behind this. So, yeah. Changed. Okay, I'll open it again. Maybe there's some problem. Yeah.
So.
Yeah.
Okay. So I will not scroll much. However, I see some filling defects in the main pulmonary arteries on both sides and going to the segmental branches. This hypodense filling defect suggestive of the presence of pulmonary acute pulmonary embolism. I would review this findings also in the lung window to check if there is any associated lung infarction. So this is an emergency. I will convey these findings immediately to the referring physician to start the proper management for pulmonary embolism and check for any underlying pathology like deep venous thrombosis of the lower limbs.
Okay. So what are the other features you would look for in a case of pulmonary embolism in the lung? One, you told infarct. Is there anything else you would look for in the lung and anything else in the mediastinum?
In the mediastinum? In the lung, we would see the
embolism. Yeah. In the lung, you can see infarction. What else?
Infarction. If we have aneurysmal dilatation of the pulmonary artery secondary to the thrombosis, the patient could develop also a pleural effusion.
Okay.
The patient could develop also pulmonary edema, pulmonary congestion. This also all the possibilities of.
What happens consequential to pulmonary embolism to the heart?
The patient will go for right side heart failure and cardiac ambulance.
So what do you see in that on CT?
So see right ventricular dilatation and will be the septum, the cardiac septum will be deviated to the left side and will be seeing in the upper abdominal cuts reflux of the contrast into the IVC.
Okay. So do you know how do the patients die in case of severe pulmonary embolism? What is the most common cause of death in severe pulmonary embolism? What's
the common cause of the pulmonary embolism?
Yeah, how do the patients die of pulmonary embolism?
Of the cardiac tamponade.
Okay. We'll go to the next case. Yeah, this one.
So this is a frontal radiograph of an adult patient, elderly patient, where I can see that there are ill-defined confluent opacity seen at the upper lung zones associated with, there are generalized decrease in the lung volumes, and there is upper lung zones, bilateral upper lung zones, ill-defined asymmetrical opacities with areas of central lucidity suggestive of air bronchogram. The rest of the lung fees show reticulation and small nodules. I cannot appreciate any pleural effusion or calcified pleural plaques. The bony structures are unremarkable. as well as the cardiomediastinal shadow. So in summary, we have reduced lung volume with bilateral upper lobes ill-defined confluent opacity, the possibility of progressive massive fibrosis is a possibility. So I will correlate with the clinical findings of the patient if he is known case of to rule out the possibility of exposure to occupational dust, and correlate with any previous examinations to see the progress of this case. I can also notice some tracheal dilatation, which denote the chronicity of these findings. So the possibility of progressive massive fibrosis is the most likely diagnosis in this case.
Okay. So can you tell me some causes of upper zone fibrosis?
Yeah, upper zone fibrosis would happen in the ankylosing spondylitis, the pneumoconiosis, co-workers pneumoconiosis, like the silicosis and like the silicosis. Other causes would include the TB and the sarcoidosis.
Okay, this is the next case.
So this is a 56-year-old male patient presented with diffuse abdominal pain and recurrent attacks of fever and easy fatigability.
You can take the control.
So this is a scout image of the CT abdomen and pelvis, where I can notice some streaky air lucences at left hypochondrial region, which are quite ill-defined. And I think also they are tracking towards the diaphragm, the left hemidiaphragm, suggesting that these possibilities could be, that this air could be in a retroperitoneal compartment rather than intraperitoneal compartment. Should I go for the images?
Yeah.
Yes. So can you scroll for me? I feel it's quite difficult.
Yeah, I'll do that. No problem.
So this is contrast enhanced CT scan of the abdomen in the portovenous phase. In the upper cuts, I can appreciate that there are retroperitoneal air encasing the left kidney and tracking into the posterior perinephric space as well as the peripancreatic space. I cannot appreciate any air within the collecting system, and the renal parenchyma appears homogeneously enhanced. There is also a collection in the left paracolic gutter with thickening of the pericolic fascia. These changes are seen extending into the left iliac fossa. So this is the Retroperitoneum, and and the kidneys appears unremarkable. So vision present with fever and fatigability. So I would look for the cause of this retroperitoneal air. It's not an emphysematous pyelonephritis because the kidneys appears normal actually. Maybe a retroperitoneal abscess.
Okay. So what will you do?
This is an emergency findings. Need to be communicated with the surgical team for immediate drainage, and the interventional radiologist may be also involved in the management of this case for drainage and further assessment by cytology and proper antibiotic injection.
Okay. Can you tell me some causes of pneumoretroperitoneum?
Pneumoretroperitoneum can the most common cause could be pericolic abscess from the any of the right or left colons, or perforation.
Perforation of
the right or left colon, maybe if any diverticulitis or something in the right or left colon.
Which
Take
part
also the first part,
which perforation
the
is
right or
most?
the left colon.
Okay. Okay, let's go to the next case.
So 56 years old male patient.
So that's an IVP series. That's a controlled film. You can have a look at that. And then
So in
you can see the control, yeah.
So in the control film, I cannot appreciate any frank abnormality. No radio-opaque calculi could be seen. No pathological calcifications. Gas bowels are seen having a non-specific pattern. Can I go for the next image?
Yeah, sure.
So this is a nephrographic phase. I can see that the left renal shadow is obvious, while the right one is not opacified at the nephrographic image. And in the excretory image, the left kidney excreted normally. The right pelvic cell system appears abruptly ending at the region of the pelviureteric junction. Actually, both ureters are seen medially displaced over and coursing towards the midline. So with quite mild dilatation on the right side. So this could raise the possibility of retroperitoneal fibrosis, which encases both ureters and causing this mild right hydroureteronephrosis and upper hydroureter. I will convey these findings to the referring physician and request further assessment by contrast enhanced CT. If retroperitoneal fibrosis is diagnosed, this is also associated with other autoimmune disease like thyroid, Renal's thyroiditis or Renal's thyroiditis. So I will convey my findings and correlate with any clinical data available for the patient.
What is the most common cause of retroperitoneal fibrosis?
Idiopathic.
Okay. And you know some other causes?
It could happen in lymphoma, can lead this post-radiation, can lead this,
What else?
don't remember, maybe TB also can lead to retroperitoneal fibrosis. I'm not sure about other causes.
Okay. So we have time for another case, Dr. Asad?
Yes, we have. We have
Okay.
2 minutes.
Okay.
So this is a male patient, 75 years old, present with left flank pain with hydroureteronephrosis that reported at recent ultrasound evaluation. So this is again IVB series. I can see that left percutaneous nephrostomy tube is seen, and it is adequately draining the left pelvic cell system. The ureters appears mildly dilated at its proximal upper 2/3. This background of the iliac bones show multiple lytic and sclerotic changes. So I will see that the right kidney is not opacified. However, maybe some calcifications or some ill-defined contrast, wispy contrast appearance. I cannot appreciate the right kidney at all, or the pelvic cell systems or the ureter. The distal end of the left ureter in the bladder seen surrounded by a small area of lucency, suggestive of maybe small intravesical erythrocyte. So in summary, I cannot see the right kidney, right pelvic cell system, and there is maybe sclerotic changes or osseous lesions in the pelvic bones, and the left pelvic cell system is adequately drained. Still mild residual dilatation in the proximal ureters, and there is filling defect in the around the distal left ureter, suggestive of intravesical erythrocyte. So I will convey the findings to the referring physician and correlate with any clinical history and ultrasound examination for the bladder to assess the possibility of erythrocyte and check the condition of the right kidney.
Is there any abnormality in the left ureter which is persistent in these images?
See, it is proximal dilated and start to narrow at the region of the sacral ileum. So maybe there is a lesion at the region of the sacrum ileum infiltrating the ureter at this point. So maybe this also require further assessment by cross-sectional images and CT to assess if any mass infiltrating the ureter at this point.
So what procedure is this?
This nephrostogram. That's why I can see the right.
Yeah.
So this left nephrostogram. That's why I can see the right ureter. Right.
Yeah. So initially you said IVU, I think. So
Yeah.
Yeah.
Time is
Okay.
over.
Okay, so let's start from here. So very well done, Dr. Samit. So this case I basically showed because, you know, instantly everybody calls it IVU. And despite of the fact that they are not doing conventional procedures a lot, but still we do encounter such cases in exam. That does happen. They do, suddenly such cases pop up and we are not expecting that. So as now you know that there is no abnormality on the right side at all because it's a nephrostogram on the left side, and that's why it's appearing like that, you know. And there is a filling defect in the mid ureter because there is a calculus there which is causing upstream dilatation. So this main purpose of showing me was the nephrostogram only because yeah, and this one pulmonary embolism, of course, very well done. And you told about the emergency thing, which was very important. You immediately highlighted the emergency part, which they expect that. So I think the few things which we look in pulmonary embolism, as you very well said, infarct. Another is you can even look for septic emboli in the lungs. Yeah, and these things you should say on your own, like I would look for in a case of pulmonary. I mean, that helps you get more score rather than them asking. I would look for right heart strain. See, there is right heart strain in this case.
Yes, right heart strain. Yes.
So there is flattening of the interventricular septum. There is right heart strain. So once you identify these things, your score gets better. And then you can further comment that if it is even more severe, there is paradoxical bowing and right pulmonary trunk is enlarged. And of course you said about the IVC contrast reflex, you said. And then risk factors also you mentioned that hypercoagulable states we will look for. All that was very good. Yeah, this one, once you saw this image, you told this is retroperitoneal fibrosis. One important cause of, you were right in saying that most common cause is idiopathic, but one important cause is drugs. And we should know the name of at least 3 drugs because they do ask like that. So
bleomycin something. I think bleomycin one of them. I'm not sure.
Yeah, bleomycin is one of them. There are hydrolysine, beta blockers, ergotamine, methyl dopa. I mean, these are the drugs. I mean, at least 3 drugs you should know because very commonly it is asked. And then one differential you should mention. Always in every case, unless it's a classical. And unless, see here you don't have a CT, so you are thinking it is retroperitoneal fibrosis. Even if you have a CT, still you should say one differential as a lymphoma. And then, yeah, because the lymphoma, then you can comment on, like, if lymphoma is there, it would be cranial to L4-5 most commonly, and non-lymphomatous retroperitoneal fibrosis mainly centered at L4-5. And then Erdheim's Chester, that you might not say it's fine, but lymphoma with RPF, one differential, if you say, it's always good.
Yes.
Yeah, because sometimes it does happen that it is not the characteristic one, but always better to tell one differential at least. This one was very correctly you said pneumoretroperitoneum, and the cause was retroperitoneal abscess. So as you couldn't see any other cause, I was asking about the causes of pneumoretroperitoneum. So first of all, I would want to say one thing, like once you saw the scout, no? Here there is a problem that you can see that there is the entire series is there. There in exam, we don't even know whether they have the series with them. We just see the scout. We don't know that they have the rest of the images with them. So that is one thing. So here you saw the rest. So you said, can I see the rest? Otherwise, when you just see this X-ray, you would immediately say that this is an emergency. First of all, you will tell that this is an emergency. I would urgently convey my findings and to the surgeon, and then you would talk about CT. So when we see the CT, it was very obvious, you told. And regarding the causes of pneumoretroperitoneum, which I was trying to emphasized was duodenal ulcer perforation is a very common, actually peptic ulcer, duodenal ulcer is the most common cause.
Yes. Okay.
It's the most common cause of pneumoretroperitoneum, and then instrumentation. Then of course you mentioned ascending, descending colon, diverticulitis, all that you told, all that was very good. Then even rectum, sometimes foreign body insertion, all those, I mean, you don't need to tell all the causes. Just, I think duodenal ulcer perforation is one cause in pneumoretroperitoneum should always mention, because in daily life also, that's the first thing we search for when we see retroperitoneal layer. So, and then this was progressive massive fibrosis, as you very well said. I mean, and you also mentioned that we should look at the previous images, which was good, because then in that case, they will show you the previous image. Unless you ask, they will not show. And when they show in this case, it would be the same. So that would confirm the diagnosis. So, and there are no acute symptoms in this case. So that was fine. And this one, yeah, you told that these are cavities ones. Basically, you know, one thing which you could have done in this case was you could have quickly come, like rather than describing every lesion, see broadly you can see there are multiple cavitary lung lesions. You could see one lesion in the right lower zone. You said there are lucencies and
because my thinking process in the beginning that this left lesion is a mediastinal lesion, then these are other two lesions. That's why this my thought process in the beginning. Then after this, I mean, I corrected myself during the description.
Yeah, I understand. That does happen because one wants to be safe also. So once you come to the conclusion of multiple cavitary lung lesions, then I think when you're asked about the causes of cavitary lung lesions, it's good if you are more systematic, like infections, then malignancy. In malignancy, you can tell primary and metastatic, and then you can come to autoimmune, then vascular, like that.
Yes,
you can it looks good if you categorize in the, those are the basic categories which apply in every particular, you can apply everywhere actually. So like autoimmune and rheumatoid arthritis, and then you can start speaking, you know, autoimmune rheumatoid arthritis, I will look for erosion of the lateral end of the clavicle, like that. Malignancy, when you say malignancy, when you say, then head and neck cancer are the most common squamous cell carcinoma to cavitate. So then you will you can say that I will find out if the patient is a known case of any malignancy like a head and neck cancer, like like that you can say. And for vaginous, I was asking about how do you diagnose? So basically, biopsy was the answer. So yes, I know that you were correct in saying that renal and sinuses and pulmonary also, but the confirmatory diagnosis is on biopsy.
Okay.
Vaginous granulomatosis, and this then yeah. So those are the
so much,
things.
Dr. Thanks so much. Thank you. Thank you.
So I'll just close these cases and we'll
the next candidate will be Dr. Mohan.
Yes, I'm here.
Okay.
Just give me a second, I'll open these cases.
Sorry, Dr. Maria, you are going number 4, please.
So Dr. Mohan, this is your first case.
Yeah, vague abdominal symptoms for investigation in a 75 years female patient.
You can take the control.
Control.
Oh, you want me to scroll?
I don't know how to take control from my side.
Okay.
Just click on the view options and you will see a request control option on the top of your screen.
Okay. View options. Okay. Request for, yeah, got it. Yeah, and now I'm able to control the mouse. I'm given a CT abdomen. It's a plain scan. Before commenting, I would like to have a quick look in the scan. I can see there is a calcified lesion in the left kidney. It is left kidney is fully contracted with multiple calcified areas. I can also see lobulated exophytic lesions. arising from the left kidney, and the right kidney is fine. I don't see any areas of lymphadenopathy in the abdominal stations. I can see few granulomatous, calcified granulomas in liver and spleen. So I'm thinking of granulomatous disease, which is causing calcified granulomas in liver, spleen, and I'm thinking it's also causing same abnormality in the kidney, which is calcified now. So I'm thinking of tuberculosis in this case. So I would like to have any previous investigations of the patient, so which I would correlate with, and if not, I would like to have a CT chest to look for any pulmonary tuberculosis features, and yeah, I would correlate with the history of the patient.
Yeah. The patient had some infection long time back. Though they are not having the history, they just told they had some infection in the chest.
So in that case, I would suspect it as pulmonary tuberculosis, and I would inform the findings to the referring physician, and recommend CT chest if possible, to rule out pulmonary tuberculosis. And this I think is a putty kidney, like
Yeah.
putty kidney of left side.
So, so what are the stages of renal tuberculosis? Can you tell me about how does it look in the beginning and how does it progress on imaging?
No, I don't know about that.
Okay. Let's move on to the next case.
Recently unable to walk in a 2 years old infant patient. Okay, I am given with CT brain images, axial section. It's a pain study. I would have a. Okay. The striking abnormality I can see is there is hydrocephalus with transependymal ooze, and there is also a mass lesion in the posterior fossa in the right cerebellar hemisphere with central hypotenuse areas. The lesion is causing significant adjacent cerebellar edema, and there are no obvious areas of calcification in this, and the lesion is compressing the fourth ventricle, and it's displaced towards the left side, and I don't see any cystic changes or necrotic changes, no calcification in this. And in a pediatric patient with a mass lesion in the posterior fossa, which is hyperdense, I would think of ependymoma or medulloblastoma. So I would like to do first I will inform the neurosurgeon about the hydrocephalus to decompress it as soon as possible, and then I would like to advise for a MRI brain to look for the to characterize the lesion better.
Will you advise for anything else also?
For hydrocephalus, I would recommend, I would alert the patient, neurosurgeon to decompress at this zone.
Anything else after informing about hydrocephalus and shunting and MRI brain? Anything
MRI,
else?
I would also screen the neurospine for any drop metastasis because it is both ependymoma and medulloblastoma are known for drop metastasis.
Okay. So which one do you think is more likely in this case?
As the lesion is hyperdense on plain CT, so I am thinking of medulloblastoma.
So what is the treatment commonly done for medulloblastoma?
Chemotherapy with surgical excision.
Anything else?
No, I don't know.
Okay. So did you go to the next case?
I'm given an X-ray of knee, bilateral knee joint of a skeletally immature patient as the growth plate is unfused, and I can see there are no evidence of any abnormal lytic or sclerotic areas, and no evidence of any fractures in this. No evidence of any obvious any soft tissue swelling, and the epiphyses are normal. No evidence of any enlargement of the epiphyses, and no evidence of any metaphyseal flaring. And
Anything striking about this X-ray?
striking. There is some hyperdensity in the metaphyseal region.
The bones which you are seeing, the bones which you are seeing are normal. The soft tissues which you are seeing are normal.
Okay.
Does that give any clue? So what all bones you look for?
Look for the femur with like seeing in metaphyseal diaphysis and epiphysis, and same in both legs of leg, both bones of leg like fibula and tibia. Joint space is fine. No evidence of any widening or any effusion.
Okay, they had some other X-rays also. I'll show you those. The same patient.
Okay, same patient. I'm given X-ray of pelvic bones, and I think there is horizontal acetabular roof in this, and there is flaring of bilateral iliac bone. Flaring of bilateral iliac bone with
Anything else? Anything else with the iliac bones? Anything which you can correlate? The patient did this X-ray and the previous X-ray. Does that correlate? In the same patient, we did a knee X-ray and then we did a pelvis X-ray.
There is, I think, there is some tombstone appearance of the iliac bones with champagne glass pelvic inlet appearance and horizontal acetabular roof. So I'm thinking of some congenital hereditary disease.
You are right. You are right that it's a congenital problem. You are right. But any other congenital problem you can think of and just have a relook at the iliac bones?
Iliac bone. I can see sclerosis or hyperdense areas in the bilateral iliac bones. I think it has they are iliac horns.
Okay.
So bilateral iliac horns is seen in Nail-patella syndrome.
Now can you see that X-ray?
Actually, I don't remember the findings in knee joint of Nail-patella. Actually, maybe widening of intercondylar notch in this.
Okay. And this is the X-ray of the same patient. Another X-ray.
Another X-ray.
So what else we'll see in this? I mean, it's okay if you don't remember the entire series, but it's a congenital problem that you have mentioned. So anything you will suggest for this patient to the referrer when you see all these findings and you suspect Nail-patella syndrome? Will you suggest anything?
Yeah, I would refer this patient to the orthopedic MDT. Yeah, I'm not sure actually. This.
Okay, no problem. We'll go to the next case. Yes.
I'm given a CT brain which is showing bilateral orbit, and which is a post-contrast study. I can see there is a mucosal thickening in the left.
You can scroll. You can
Yeah.
scroll. You can first see the entire series. Yeah.
Yeah, there is mucosal thickening in left maxillary sinus and also ethmoid sinus, or also frontal sinus. There is soft tissue swelling around the left periorbital region, and also including the preseptal tissue of the left orbit, and the eyeball appears fine, the lens seen normally, and I'm looking for any inflammatory changes extending into the left orbit. There is some haziness in the left left orbit as well in the intracoronal space compared to the right side. And
any comment on the vascular structures in relation to this abnormality?
I would like to have a look at the superior ophthalmic vein and the cavernous sinuses.
Okay.
Because they are prone for thrombophlebitis in periorbital infection. And however, the cavernous sinus appears fine. I think it is not bulky and showing normal enhancement. So unlikely to be Tolles-Hunt syndrome.
You compared it to the opposite side?
I think, yeah.
Okay, so what will you do? What is the process going on and what will you do?
I think there is sinusitis with possible extension of the infection into the or left orbit as well, and the periorbital region, with result with possible endophthalmitis. It's possible endophthalmitis, and I'm not sure about the ophthalmic vein. I don't see any hypertensity or dilated vein over there. So, however, I would inform the findings of referring to physician and also alert the ophthalmic.
What about this section? You just mentioned about ophthalmic vein. Can you appreciate ophthalmic vein in this section?
Yeah, this side on the lateral end of the orbit wall, I can appreciate one dilated vein here, which is hyperdense.
No, where is the superior ophthalmic vein? Can you point out?
1 second.
You will look for superior ophthalmic vein and cavernous sinus you mentioned. Can you please show superior ophthalmic vein?
I think this is the superior ophthalmic vein, this one.
Yeah, okay. So what do you think?
Okay, yeah. Compared to the right side, I can see there is hypodensity. It's not showing a normal enhancement. So maybe it is a thrombosed on left side. So I would immediately alert the ophthalmologist about the emergency in this case, and to operate as soon as possible to salvage the left orbit.
Okay. So what is the most common cause you think of orbital cellulitis?
Like infection extending from the adjacent sinuses.
Okay. Anything
And
else is a
also,
possibility?
yeah, in the nasal vein, there is called some danger area in the nasal region as well. So any infection from the nasal vessels can, from the orbital, from the ocular region, periorbital region can extend up to the orbit.
Okay, okay. So we have time for one more case, Dr. Nuran.
Yes, madam.
Okay, please continue with this case.
A middle-aged male presented with abdominal pain, fever, and nausea for a week in a 40 years male patient. Abdomen fever and nausea. I'm
You
given
can
with
scroll. You can scroll the images.
yeah, yes.
And-
I'm given CT abdomen post contrast study. Patient is having abdominal pain and fever, and I can see there is wall thickening involving the sigmoid colon. With adjacent fat standing in the pelvic cavity. It is not continuous. It is with involving skip area, discontinuous wall thickening involving the sigmoid colon, rectum, and I'm looking for similar wall thickening in this limited images of this. So the
Patient has
slide-
severe pain. Patient has severe pain and fever.
Okay, I'm looking for any other inflammatory cause in this patient, inflammatory or infective. I'm looking for any diverticulitis. In this case, there are no evidence of any diverticula. I can see free air foci in the abdominal cavity, in the pelvic cavity, with
Okay.
surrounding fat stranding. So which can be collection with possible abscess formation.
So what will you do?
I will inform the deferring physician and also gastrosurgeon about the bowel wall thickening, which could be, I think it is a inflammatory bowel wall disease with possibility of abscess formation in the pelvic cavity. So
If I tell you that's not an inflammatory bowel disease, can you search for the cause of problem in this case? There are other images. You can see the cornel also. Why has this happened? Can you look for it?
yeah, I'll try to. The SI joints are fine, and kidney shows few renal cysts. Looking for appendix and diverticuli. However, I don't see any inflammatory changes in the right RF region. And
Look at that region only, which is abnormal in that region.
okay.
Could you see
Sorry.
something abnormal? Something which is standing out?
I can see a linear hypertension structure adjacent to that region. So
What can it be?
can be a foreign body.
Okay.
In this, with resultant possible perforation of the bowel at that region.
Okay.
As it is a very sharp object.
Time is over.
Okay. So very well done, doctor. This one was an actually ingested foreign body only. It was ingested toothpick by the patient, which was impacted in the sigmoid colon.
Okay.
And thereby piercing the colonic wall, and that was a localized perforation here. So that was the cause of pain, and then it got infected, and that's why the patient had fever. So yeah, I mean, that was quite good. You picked up all the findings. You also found out the cause. And only thing is, when you have found the abnormality, so try to be around that. You can more or less see the rest of the scan appears to be normal. So just focus more on that area. Maybe you'll find out something more there only. You know? Otherwise, you told everything about that case. Now this one, coming to this case, now this was orbital cellulitis, as you very well said, consequential to the paranasal sinus disease, and paranasal sinusitis is the most common cause of orbital cellulitis. Now here, once you see such a thing, see, that's what I think. that you can describe it as like, okay, there is a swelling, soft tissue swelling, and there is thickening, preseptal soft tissue, no postseptal, no bony destruction or sinuses, all that. Then these findings are indicative of infective cause, and I would urgently inform the referee because orbital cellulitis is an emergency. So,
Yes.
I mean, very quickly, you should say, I will urgently inform the referrer as this patient will need a immediate management. So, I mean, that is one thing you should point out because orbital cellulitis is amongst those emergency cases which they expect us to point out. Okay, and then what will they do for management? Obviously, they will do surgical drainage and antibiotics. And then if you compare the cavernous sinus, see here and see here, you very well picked a superior ophthalmic vein, and you also said that you will look for it, which is very good because sometimes even if we say and we are not able to find, it's still sometimes fine because they know in the exam pressure you might not be able to pick up, but at least they know that you know what to look for. So it was very good that initially you said that I will look for superior ophthalmic vein and cavernous sinus. So at least they know that you know the thing and you will look for it in your routine practice. When you have more time, you will be able to find it. So here it's okay if you couldn't pick the cavernous sinus thing, but that's completely fine. It happens in the exam time. That can happen. It's completely acceptable. This one, so see, this was a case. Such cases they do show, and they start like this only. So there is no patella. If you can see,
Oh,
there's
yes.
no patella here, right? So, I
Yes,
mean,
doctor.
that's a case of, and you also said Nail-patella syndrome. That's why I came back to this X-ray again. I thought now you will pick up the patella, but maybe you didn't remember the spectrum at that particular point of time. That's perfectly fine. Now you will know because Nail-patella syndrome, they have asked and they do ask. So that is posterior iliac horns. I think that's also quite obvious in this radiograph. It doesn't have horizontal vestibular roofs or achondroplasia you were thinking of, but this doesn't look like that. And this one is the hypoplastic radial head. That's okay if you don't know about hypoplastic radial head, but at least when you see this radiograph, see there is something wrong with the radius. You can say that this radius
Yes,
looks
correct.
abnormal. The radius looks disproportionately small or dysplastic or hypo. Something you can say like at least tell that it is abnormal.
Yes,
So
doctor.
yeah, and then I asked about what will you suggest. So suggest is once you know that if you know about Nail-patella syndrome, what they expect us to tell on our own is that we'll suggest renal function test because it is associated with renal abnormality commonly. So we'll suggest a nephrology referral or we'll suggest renal function test and ultrasound of kidneys. So then, I mean, that is something which we should be saying. And then of course you mentioned about MDT, which is right, which would include ortho, pediatric, nephro, everything. But nephro is important to mention in Nail-patella syndrome. And if you know it is autosomal dominant, then it's all the more better. That's fine. Here,
Okay.
it was quite good. You told everything. So one thing I would like to point out in this, just take a few seconds to see the images first. You can do that. It's not wrong. Like you can say, like, I'll just go through the set of images and you can take 5 seconds in that process. So what will happen is your whatever you say will be more systematic and organized, and that itself will tell them that you know the answer. Like in this case, once you started, you said there is hydrocephalus. Then you looked at, then you said there is also a mass. So, I
Yes,
mean,
doctor.
once if you would have gone through the images completely, then you would have said there is a mass in the posterior fossa with resultant upstream hydrocephalus and CSF movement. That sounds better. And that tells them that you have seen the images. So, I mean, it's absolutely fine if you take few seconds before commenting because see, in our routine practice also, we do take some time. We can't tell instantly and they understand that, right? I mean, and
Yes,
and and first thing, even before telling medulloblastoma or ependymoma, once you see that there is a mass, you can say there's a mass leading to upstream hydrocephalus. Then you can say at this point I would urgently inform the referrer for management of hydrocephalus because that's what they are looking for, urgent finding. So and then coming back to this case, the differentials for this case would be medulloblastoma or ependymoma, and then I would do a further imaging before sending the patient out. I will do MRI brain and spine as spine later on you said, but yes, and management regarding medulloblastoma, it's very radio sensitive. So yeah, radiation is a plays a very important role with medulloblastoma. That is one thing you can say if you know. Yeah. This one is putty kidney perfectly said. I mean, you said everything about this was like a spotter kind of a film. And the another clue was these calcifications in the spleen. See the granulomas in the lung.
Yes, yes, doctor.
Yeah, and the liver. So this was perfectly fine. You said, I mean, there was nothing more to it actually. So simply a putty kidney. But what happens is, I mean, you picked up and you said immediately. Sometimes we get confused. There in exams, anything can happen. So good, you did. Very nice. We can go to the next candidate.
Thank you,
Just
doctor.
open. Yeah, you're most welcome.
Dr. Ankur is the next one.
Just a second. Okay. Yeah, so this is your first case, Dr. Ankur. You can
Okay.
take the control and scroll.
Okay.
Or you want me to do? Anyways, whatever you are comfortable with.
I asked for the remote.
Yeah, I have done that.
Okay. But okay. Yeah, I'm able to control now. Okay, so I've been provided with the contrast enhanced CT scan of abdomen, axial sections. So I see a expansile osteolytic lesion in the posterolateral portion of the right 11th rib with associated cortical destruction. The visualized portions of liver and spleen are normal. I'm trying to look for any renal mass. So both kidneys appear normal. So
You can see the complete series. There are multiple
okay.
sets of images. You can go through them.
Okay, so this is a coronal image of the same patient. I see the expansile destruction of the right 11th rib again. I do not see any obvious mass lesion in the visualized abdominal solid organs, and no obvious lymphadenopathy. Let's see, coronal bone window. The rest of the bones appear normal. So based on these findings, I'll see there is chest also available, or this is just bone window.
That's the bone window. Yeah, that's just to
Okay.
see the bones better.
Yeah. Okay. So yeah, I do not find any other abnormality apart from the expansile osteolytic destruction of the right 11th rib. So my differential considerations for this patient include metastasis from
You
like
said
thyroid
you said expansile osteolytic destruction.
Yeah, expansile osteolytic lesion in the right 11th rib. Yeah.
Okay.
Yeah, so there are areas of cortical destruction as well. So yeah, first thing I'll be excluding is any primary lesion, and this might be metastasis. Another possibility is plasmacytoma.
Okay.
So I'll correlate with the clinical history and advise bone scan to look for any other lesions in rest of the body. If there are no other lesions, I'll suggest referral to the regional bone tumor center for biopsy and further management.
Any other differentials which come to your mind for this appearance?
Like I see cortical destruction. Otherwise, there like solitary expansile lesion can be fibrous dysplasia as well.
Okay.
So to rule that out, I'll be comparing it with any previous images, X-ray or
Yeah,
CT.
there was one previous X-ray done which showed this similar. I mean, it was just the same, and there were no other. That was done 5 years back, so it was the same.
Okay, so if it's long-standing, then I'll be thinking of a indolent lesion, most likely fibrous dysplasia in this case. So
Do you know of any associations?
If there is a polyostotic fibrous dysplasia, then it is associated with the precocious puberty, McCune-Albright syndrome or Masbrod syndrome. So those are the associations with fibrous dysplasia.
What do you see in Masbrod syndrome?
Like I have not seen it in practice yet.
Which is more common, polyostotic or monostotic?
Monostotic is more common.
Okay. What are the other characteristic appearances of fibrous dysplasia? For example, if there is an X-ray of pelvis, what would you see?
Then I'll be looking for classical Shepherd's crook deformity in the femoral neck.
Okay.
Yeah, the classical appearance is usually ground glass matrix with the expansile lesion.
Okay. We'll go to the next case. This one. Just a minute. This one you have done, right? Okay. No. Next
Yeah,
is this.
okay. 40-year-old male patient with recurrent right lower abdominal pain.
So this is right lower abdominal region ultrasound.
Okay.
You can scroll if you want, or I can scroll for you. You want to
I'll
scroll?
Yeah, I'll scroll. Okay. So I've been provided with selected ultrasound images of right lower abdomen, both longitudinal and transverse sections. There is an elongated hypoechoic structure seen on the longitudinal section, giving a target appearance on the transverse section. It shows areas of vascularity on color Doppler imaging. So
the patient has pain. What do you think it can be?
So yeah, my differential considerations here are intussusception. Seeing this appearance, it gives appearance of bowel within bowel.
Are you seeing bowel within bowel? Okay, so what will you do next?
I'll do a cross-sectional imaging, like contrast
Okay,
CT of
that's what
abdomen.
That's what was done. You can
Okay.
have a look.
Okay. So I've been provided with axial sections of contrast enhanced CT scan of abdomen. I'm looking at the bowel. No obvious dilated or thickened bowel loops are noted.
You saw some
Yes.
abnormality in the right lower abdomen in ultrasound. Can you correlate that abnormality on CT?
Yeah, I'm trying to search.
Okay.
Uh, So I see a circumferential area of small bowel thickening in this region, in the
Okay.
right iliac region. This is terminal
Can you
ileum.
scroll very slowly here? In that
Okay.
particular region where you saw the wall thickening, just scroll very slowly if you can appreciate something more.
Okay. Okay, so like it's not continuing with the bowel.
Okay, no, it's, I mean,
Um,
okay, you can see the rest of the series. Maybe that will help you.
Okay, I'll see a zoomed
See
image.
that. Yeah, you can see that. Though in exams, they won't give that.
Okay. Oh yeah, it's not continuing with the bowel and there is a central fat density area within it. So findings are suggestive of epiploic appendigitis.
Can you show me the fat density?
This one, though in my routine practice, I'll see it with the marker because the window is not wide, so both hair and fat will appear dark.
So if I tell you that's air,
If that's air, then it can be an appendicular abscess, appendicular mass or appendicular abscess.
where is the abscess?
Yeah, okay. It's communicating with the tip of appendix. So, yeah.
So what are the differentials for right iliac fossa pain? What will you look for in a case of right iliac fossa pain?
So, I'll look for, firstly, the most common is acute appendicitis. So, it can be associated with appendicular perforation, mass, or abscess. Then there can be appendiceal tumors such as carcinoid.
Here, did you
Or
see the appendix? Here, appendix looked fine.
no, it's communicating with this lesion, this one here.
I think appendix is fine. Anything else?
This I feel there is some communication on zoomed image. I am
So
like
what it can, if I tell you
this
that
one.
appendix is fine and I can see the appendix.
Okay, if the
Appendix is
appendix
pain.
is fine in this, yeah. If the appendix is fine in this case, then it can be like a epiploic appendigitis or like
Okay, let's go to the
sometimes.
next case. We'll discuss this later on. Yeah.
Okay.
See this one more case. Yeah. You can scroll the images. So patient presented with headache. You can see the entire set if you want.
Okay.
You can take the corners. You can take this T2 fat set, I think. Yeah.
Okay, this one. Okay, fine.
Take this, yeah.
So I've been provided with the of brain focusing on the orbits. So I see dilatation of the bilateral perioptic CSF sleeves with mild flattening at the level of insertion onto the eyeball. So my concern is for benign intracranial hypertension. So in my routine practice, I'll look for other features that include attenuation of the dural venous sinuses, most commonly
We
the
have a
lateral.
venogram. We have done a
Okay.
venogram here.
Okay, okay. This one. Yeah. Okay,
So what will you see in the venous sinuses?
there
In a
is
case of benign intracranial hypertension?
it will show attenuation of the dural venous sinuses, most likely in
Okay.
the lateral portion of transverse sinuses.
Okay. So, and what else? What else do you see in benign intracranial hypertension? Anything else
Then
in the
there
brain?
can be, yeah, partially empty sella, like there is compression of the pituitary parenchyma.
Okay. So it's commonly seen in which age group and which gender?
It's more common in women
Okay.
of
Any associations you know of?
Mm, no, I'm not sure.
Okay. So
Yeah.
how are such cases managed?
So if there is no associated cause and it's idiopathic, so usually diuretics or like acetazolamide, drugs like that, which lower the body fluids,
Okay.
they can help in benign intracranial hypertension.
Okay. Okay. So we'll go to the next case.
Yeah. Okay, 50-year-old male complaining of abdominal pain.
Yeah, multiple radiographs done for this patient, so you can see them one by one. You can look at all the radiographs and then
Okay, then I'll start commenting.
yeah, then you can tell your finding.
Okay, so I've been provided with multiple radiographs of chest and abdomen. So I'll start with chest. There is the bilateral lung fields are clear. Few patchy areas of atelectasis are seen in bilateral lower zones. The cardiomediastinal silhouette is normal. So the abdominal sections show dilatation of transverse colon with the colon cutoff sign. So given the history of abdominal pain, I am concerned for acute pancreatitis. I do not see any radiodense gallstones in this radiograph. So if the patient is presenting with the central abdominal pain radiating to backs, then I'll suggest an ultrasound of abdomen and correlation with serum amylase and lipase to rule out acute pancreatitis in this case.
Can you tell some other causes for colon cutoff sign? Other than acute pancreatitis?
Can be due to colitis or a mass in the colon like tumor.
Okay. Okay. So what will you do next for this patient?
So if I'll suggest
you have
ultrasound.
mentioned, yeah, you have mentioned about the tests and the blood test correlation and discussion with the doctor regarding imaging.
Yeah, then I'll proceed with the contrast enhanced CT scan of abdomen to look for associated complications, any pseudosis. Yeah, okay.
Time is over.
Okay, so very well done, Dr. Ankur. So especially in picking up this colon cutoff sign, it was really nice. You just picked up instantly.
Okay.
That is what this case was mainly for, because if you don't pick up that, then it will not move forward. They will not go to the CT if you don't pick up this colon cutoff sign. It's very classical. You don't see any gas in the distal descending colon and beyond this. So yes, acute pancreatitis is a very common cause. Other causes would be CA colon and inflammatory bowel disease, or even ischemic bowel disease is one of the causes. Ischemia is, as Dr. Curtis always says, we usually forget the word ischemia in bowel. So that is one thing we should remember. Pancreatitis, of course, is the most common cause. So you do see in CT that is confirmed that it's pancreatitis.
Yeah. Okay.
So that is the cause of colon cutoff sign in this patient. And then you have said everything. You even said that you will look for complications, which was very nice. And complication could be, obviously there would be necrosis or emphysematous or vascular complications, all those things. Basically, this was for colon cutoff sign. Here, that in the distal transverse sinuses, there is some attenuation, though this is very subtle, that's fine. But you picked up this thing. Only thing is, they might not show such zoomed up images. This was like very obvious that we are focusing on the orbit and we want to show that. So that might not be the case always when they don't. When they just like they might show something like this where you have to notice the tortuosity of the optic nerve. Then when you say that, then they will show you something like this. But first you have to pick up something on the entire brain images. That's how usually, because if they show this, then obviously they know that you will tell, right? So so that's how they start. Like they always start with something in which you have to pick up, then you have to ask for it, then they will give it, and then obviously the answer will be there in that. And benign intracranial hypertension, you very well said, middle-aged females, and also the associations are like hormonal associations, hypothyroidism and hypoparathyroidism, even chronic renal failure. Treatment, you said acetazolam, I mean, you said diuretic. So another thing is CSF letting and shunting, LP shunts and all. Those are the things.
Yeah.
Basically.
Okay.
This one, this case, so if you see this only, see this is the ileum, that's fine. And you see this structure.
Yeah, yeah.
Communicating, if you see this zoomed up image, see this zoomed up, see this. So,
Yeah.
And so that's Meckel's diverticulum.
Okay, like I thought it's appendix.
Yeah, appendix you could see in this case. See, this is the appendix. This one. This
Yes,
appendix.
right.
See? So and generally, if appendix is a normal situation, it will be behind and this will be in front, Meckel's.
Okay.
So,
Yeah.
and then Meckel's diverticulum is one thing usually we forget when we come to right iliac fossa pain. We think of epiploic and appendix and we think of ileum and ileocecum, but Meckel's that's why I kept this case, because Meckel's does come up. And when you say Meckel's, if you say that, then you can talk about the nuclear medicine thing and ectopic gastric mucosa and Meckel's scan. If you pick up, then the discussion will go to that. And then, of course, the 2% rule, which is associated with Meckel's diverticulum, that it's seen in 2% population, 2 inches long, 2 feet from eye. All those things you can mention. Yeah. So, and differential can be appendicitis, but in this case, appendix is seen. But I understand it becomes very difficult, especially in exam scenario, to look for normal appendix. Sometimes you get nervous also there, but
yeah, exactly. All that takes time. Like we cannot keep
yeah,
scrolling and going.
see, these are the things I am telling you because I am on the other side right now, but it is not so easy while you are in that exam scenario. It is really a very tense atmosphere, but only thing is we have to teach ourselves to be relaxed. It's very difficult, but we have to focus at that particular time because those minutes are very, very important. Those are the decisive minutes. See, even if we are not able to pick that, at least we should see that this is more anterior. And we should say some things like, this is not fat, first of all, this is air. And fat, see, if you compare, fat is of this attenuation, air is this. So even if you can't, you were right in saying in your routine practice, you will see the attenuation. But here also in this CT, if you know this is fat and you know this is air, so you can just compare on your own eyeballing, you will know that this is not fat. So you can mention that that the attenuation is matching to air. So like that you can speak, and then if it is fat, they will say that. In that case, they will say, but it doesn't look like fat. Yeah, really that is a fat, so this is matching to that. So if you enumerate the causes of right iliac fossa pain, and if Meckel's diverticulum is one of them in your list, they might stop you there and then they will help you. But if you don't speak that, then they cannot help you. That is the thing. So you have to say that thing to make them help you.
Okay.
This was right. Once we talked about, once I told you that's not, see, it's, you were right, there are areas of cortical breach, but if you follow this, this is still following the contour of the rib. Nowhere it is like totally coming out of the rib and there is associated soft tissue mass or something. So you can see, you immediately told ground glass when I gave that hint to you, that when I asked, is it destructive? So then after telling ground glass, you were very, very nicely, you told about Shepherd's Cook and associations and everything you told about fibrous dysplasia. I think that was your first case. So we're done with your cases. So very well done, Dr. Ankur. Only thing is, just be more, don't be scared at that particular time. I know it's very difficult, but again and again, I'm saying because that will help. If you're not very scared, that will help actually.
Yeah, sure.
And they will help you. They will help you. Actually, they are there to help you. They won't scare you at all. Whatever hint they are giving, that will be very relevant. Very relevant. So you have to pick up that hint. You don't have to ignore that. That is one thing.
Okay, sure. Thank you.
Okay, most welcome.
Yeah.
Okay, now Dr. Maria.
Yes, hi.
Hi, Dr. Maria. This is your first case.
Okay, so let me start. So I'm providing with a frontal chest radiograph of a fused skeleton, probably a male patient. Most striking feature that I can appreciate, there are multiple small nodular densities seen scattered in both lungs, more pronounced on right side. In addition to that, there are few similar densities are seen within the retrocardiac region on left. I cannot appreciate any pneumothorax or pleural effusion in this particular image. Aortic arch is on the left side. Now I'm looking at my at the bones. The bones looks to me fine. No evidence of any bony lesion. So the mediastinum and rest of the costo and cardiophrenic angle looks to be normal. There is nothing. Yeah, there is some bowel, prominent bowel loop is seen sitting on just under the diaphragm. However, I cannot appreciate any free air beneath the diaphragm. So I'm suspecting few punctate calcifications within these nodular areas. So
There are no
so
calcifications.
assuming, okay, probably yeah.
That might
So
be
these are
projection.
okay, fine, thank you. So in my routine practice, I would check these on an orthogonal view, and also inquire about the detailed history of the patient, and would check the old records on the PACS to see any interval change in size or any prior disease there. So
Yeah,
keeping
patient
in
is a
view
known case of a disease. So right now the patient presented with severe abdominal pain. So we just did a chest X-ray also as a part of the study, but there is abdominal radiograph available if you can see and comment on that.
okay, yeah. So I'm providing with an abdominal radiograph, frontal projection, erect view. Most striking feature that I can see, there are multiple dilated bowel loops noted within the center of the abdomen. They are showing prominent loops and air fluid level within them. And there are multiple calcified densities seen in the right hypochondral region. They are confining within a sac, maybe within the gallbladder. The three of them are showing laminations within them. There is no evidence of any free air within the abdomen, no air within the biliary tree. Now I'm looking for any other abnormality within the pelvic region. So I'm assuming this is an intestinal obstruction, most probably the small bowel, keeping in view the central position of the bowel without overt evidence of the pneumoperitoneum. In addition to that, there's incidentally seen the few faceted lamellated gallbladder stones. So I would urgently discuss this case with the referring physician and refer this case to the surgical team. And I would also advise an CT scan abdomen, including the chest, to rule out the cause. And as you say that the patient is having already a known disease, so I would look up into the records also to check the details and also compare the scan.
Okay, can you come to a unifying diagnosis? You saw some lung nodules here, and
Yeah.
then you saw this bowel obstruction. So does any unifying diagnosis come to your mind based on this radiograph? These radiographs?
Yeah, these multiple nodules within the chest can be due to metastatic deposits from a primary sitting within the bowel, which may result in intestinal obstruction in this case.
Patient is a known case of malignancy, you are right.
So, so these can be a match, and beside that, I don't think so any other infective etiology can be presented like this because there are lack of pleural effusion and consolidations.
So we did a CT scan, as you said,
yeah.
you would say, yeah, you can go through the CT scan.
Yeah, so can you please scroll it for me? It would be kind enough.
Sure.
Since I'm using mobile. Thank you.
Okay.
So I'm providing with the unenhanced CT scan abdomen of the same patient, which is confirming the small bowel obstruction. There is a mass showing hyperdensity within it, seen within the small bowel. It's invaginating. There is a loop of the bowel is invaginating within adjacent bowel loop, and this mass probably acting as a lead point, and it's exhibiting ilio-ileal intussusception, and it's causing a transition point there with proximal upstream dilatation. In addition to that, I can appreciate there are multiple. Now this is a post-contrast image, so there are multiple enhancing lymph nodes seen, a few of them forming a confluent nodal mass seen within the right inguinal region and in right obturator space. So these are most probably from the same disease spectrum. Moreover, I'm also looking for the liver and spleen. There is no evidence of any visceromegaly, no lymph node seen in the along the gastrohepatic ligament. Both adrenal looks to me fine. In my routine practice, I would check with the whole scan, the remainder of series, and also would see the liver window and the bone window as well to look up for the further metastasis in this case. And urgently refer this case since it's causing bowel obstruction to the surgical team and oncology MDT.
Okay. So again, this
This
case,
is
yeah. So
Okay.
patient has lower back pain,
Mhm.
and the patient previously underwent some treatment for a disease.
Okay,
in the
fine.
lower abdomen.
So, okay,
in the
okay. So I'm providing with the sagittal lumbosacral spine of T1 weighted sequence of adult patient. Most striking feature that I can see, there is marrow replacement seen involving the sacral vertebra with which is revealing T1 hyperintensity, and there is rest of the intervertebral disc spaces looks to me fine, apart from the few femoral nodes, and there are few multifocal disc bulges are also noted. And now I'm looking for the intervertebral foramina. They looks to me fine. The cord is fine. And now this is T2 weighted image. It's correspond similar marrow signal is also seen within the sacrum as exhibiting T2 hyperintensities, which is suggesting the fatty replacement. So I'm assuming this must be due to some underlying radiation therapy. So now I'm more focused on the pelvis to look for some malignancy sitting there or some abnormality which may cause this this appearance. And I would also assist this in coronal view.
Your right
Yeah.
patient underwent radiotherapy for rectal carcinoma.
Okay. So these are the coronal fat set, T2 fat set images of the, is this the same patient?
Yeah, same patient. So
Okay,
basically,
okay.
right now the patient has come for lower back pain, and we are trying to find out the cause for the pain.
Fine, perfect. So these are the coronal images, fat set images of the same patient, which is again showing diffuse sort of diffuse hyperintensity and marrow edema seen sitting within the sacral part in a H-shaped configuration, and there is relative sparing of the iliac bones, and both sacroiliac joint looks to me fine, and there is no other obvious lesion seen within the iliac bone and adjoining musculature. So I'm assuming this must be an insufficiency stress fracture secondary to this radiotherapy, as patient have already undergone the radiation. So I would urgently discuss this, refer this case to the orthopedic team for casting and for further management option. Bone scan would be of added help in this regard.
Okay, so what are the other causes of sacral insufficiency fractures you know of?
So basically, it's an abnormal bone with a normal stress. So you may have some reduced bone mineral density secondary to some osteoporosis, osteomalacia, some metabolic causes like hyperparathyroidism, and due to bisphosphonate therapy secondary to some which may be used by the Paget disease patients and like osteogenesis imperfecta patients. So I'm providing with an frontal radiograph of the chest and abdomen of an adult of a neonate, and most striking feature that I can see, there is a nasogastric tube is seen below the diaphragm, and it's noted within the gastric region. And there is ETT tube is also seen, which is comfortably placed. Actually, I'm not making out the trachea. I think trachea is displaced towards right. I'm not sure whether it's appropriately placed or not.
It's fine.
Okay.
Some rotation
So
you do expect.
okay, fine. Okay, so there is bilateral lung volumes, 1, 2, 3, 4, 5, 6. So there is normal adequate lung volume seen bilaterally. There is bilateral perihilar haziness seen in both lung fields with subtle air bronchogram, which is consistent with the respiratory distress syndrome. So I'm also looking at the epiphyses. Both epiphyses are absent, so consistent with the preterm child. And in addition to that, the small bowel loop, there is non-specific gas-containing bowel loop seen. There is the absence of gas seen within the region of the rectum, and I cannot appreciate any free air. I can see some sort of buoyancy seen within the right hypochondrial region, seen projected over the right hypochondrial region,
You can
but
ignore
I'm
that.
not sure. I'm not
You can
sure.
ignore.
Yeah. Okay. Okay. So there's
So-
abdominal distension also. So yeah.
So the rest. So what are the associations with the respiratory distress syndrome?
Yeah, it's basically condition seen in the preterm babies. It's associated with the necrotizing enterocolitis, and it's also associated with intracranial hemorrhages, which can
Okay.
be a cause of death in these kind of patients. And
And what complications you expect in children with RDS?
yeah, due to ventilation, over ventilation, they can cause the pneumothoraces, multiple time pneumothoraces, and pneumomediastinum, and due to positive pressure ventilation, and also they can cause pulmonary interstitial emphysema and long-term basis the bronchopulmonary dysplasia, which can be a life-threatening situation again.
Bronchopulmonary dysplasia, how many days is the supportive oxygen, which is the beyond which bronchopulmonary dysplasia develops?
It's a long-term complication. It's a chronic complication beyond 3 months. Patient is having long-term oxygen support, then it might develop the bronchopulmonary dysplasia. It's not an acute term. In
Beyond 3
acute
months.
setting, yeah, beyond 3 months.
Any differential for ARDS?
Yeah, we can keep we can keep the neonatal pneumonia, but since there is lack of any pleural effusion, and we can't keep some pulmonary interstitial emphysema that basically
Okay,
there's no ropey kind of
that's your next
space.
case.
Fine. Okay, so I'm providing with a craniocaudal view, right craniocaudal view of the right breast. The most striking feature, there is the right breast is predominantly fatty consistency, and it's showing a fairly well-defined lobulated density seen in the inner quadrant of the right breast. In my routine practice, I would check it with another MLO view of the same breast. Yeah, so it's an outer inner quadrant of the right breast, and it's showing lobulated contour.
Which quadrant you mentioned?
Lower inner quadrant.
Okay.
And it's showing lobulated contour. There's no evidence of any microcalcification, no overt microcalcification seen there, and it's very well away from the skin. There is no obvious skin thickening, no desmoplasia, and there is no nipple retraction, and ipsilateral axilla also looks to me fine. So I will, in my routine practice, I would check it with an ultrasound. I would recall this patient back from the screening.
Based on the
patient is
mammogram, what will be the grading for this?
Yeah, it's a benign. I would grade it as M2, and
Are you sure?
and I would. Sorry.
Are you sure?
Yeah, it seems to be a benign lesion. So I would further confirm it on the basis of ultrasound, whether it's cystic or solid, and also Doppler would be then added help, and subsequently I would refer this case accordingly to the MDT setting.
Okay, we did an ultrasound.
Okay. Okay, so these are the ultrasound of the same patient. Um, it's confirming the cystic nature of the lesion, though the lesion is showing multilobulation and it's wider than tall, and it's showing multiple septi and heterogeneity within it. There's no significant flow on the color Doppler, and there are multiple thick septi and debris. So in my routine practice, I would also inquire about the axilla of this particular patient. So now lesion looks to me again benign, but it's a complex looking lesion. So I would advise a biopsy of the lesion and to confirm the findings. And,
based on these images, you think as a benign lesion? Based on the mammogram,
actually,
as well
there's
as the ultrasound?
Actually, there is no vascularity, central vascularity. So, but there are few calcification are there. So I would now grade it as U3 rather than U2, and could advise in biopsy of the lesion and followed by the further management and staging if it's turned out to be malignant.
Before that, anything else you do when you see a mammogram?
Yeah, we can do an edit views in the mammogram,
Before that,
compression view.
Before that,
clinical examination, triple assessment, in which we can clinically
what
assess
will
the
you do?
patient.
What will you do as a radiologist when a mammogram comes to you and you are in doubt?
I would
in your-
advise an MRI breast with contrast to
So
see
I said
the
before-
further.
No, I said even before you advise a compression view for this, I said, what will you do? So that cannot be MRI, right? What else? Anything else comes to your mind?
So you are asking before mammogram.
So once you see the abnormality on the mammogram, what
Fine.
will you do?
We can have further views like magnifications view and
Okay, let's
compression
move to
views.
We'll discuss that later.
Sorry.
on.
Time is over.
Okay, so we'll go back to this case only here. What my question was comparison with previous imaging. That's the basic thing.
Yeah, I forgot.
We should not forget that. That's a very simple thing, but we tend to forget that. And when it comes to mammogram, that's very, very essential. See, because if you see a previous imaging, that will really help you. In case of whether it's a benign lesion or a malignant lesion, a benign lesion would be stable over the period of time. If the patient has been having regular screening, then you would be seeing the same lesion without any interval change. That would really help you in making your diagnosis. You even don't need to do an ultrasound or a biopsy if you don't see any change. And if you do see a progressive change, that makes your diagnosis of malignancy more certain. Of course, the conclusion would be through biopsy. And here in this case, if you say, you very, very quickly you said it's a benign lesion. That is one risky thing which you did. See the speculations in the margins. It's not a smooth outline. You see these speculations?
Yeah.
It is a big, there are microlobulations and there are speculations. These margins are not fine. At this, here they are fine, but again, see these speculations. There is architectural distortion, there is speculation. Based on a mammogram itself, this is M4. It's not even M3 because there are speculated margins and it is an irregular outline. And you were right in the localizing the lesion. It's in the lower inner right breast. That's fine. And it is a hyperdense lesion. Okay. And you said the breast is predominantly fatty. I don't agree with that. There are scattered fibroglandular densities. So it's not predominantly fatty. Predominantly fatty would be like this. But if you see this fibroglandular tissue, which is very well seen in between, This would not be a predominantly fatty breast. This would be a breast with scattered fibroglandular density, and the background pattern. That's the first thing which you should mention, which you did, which is right. But regarding this lesion, it is an M4 lesion, and then you would definitely want to do an ultrasound for that, followed by biopsy. Even on ultrasound, it doesn't look benign. It's a complex cystic lesion with areas of solid, with areas of you can say solid component, and here you see there are some. It's not necessary that you will always get characteristic central vascularity. That applies in a completely solid lesion. But here you have cystic area, so the cystic components won't show you the vascularity which you are expecting. But if you see in the septations, you are still seeing vascularity, and that might be there always. It might not be there. This was a case of squamous cell carcinoma of the breast. Squamous cell carcinoma, though, is less common. But the imaging features, that's why I showed this case, because on the mammogram, sometimes when there's a large mass, we quickly think that's a benign lesion, because the margins and all, we are not focusing on that when it's a large mass. When it's a small speculated lesion, we quickly think it's a malignant lesion. So the margins are very important. That's why rest of the cases you were bang on. You told everything, nothing I can point out. You told respiratory distress syndrome, you pointed about the tubes, you told about the complications. Bronchopulmonary dysplasia, that's what I was asking, what the number of days is. More than 28 days supportive oxygen therapy. It's not more than 3 months. So chronic, it becomes more than 28 days. If there is an article on RSMA, you can check on that. And you told everything about this case. I cannot add. And in this case, when you see the sagittal images, so these fatty marrow changes, you correctly said without even me telling that it's a case of malignancy. You told that was really very nice that you told, because there's a symmetric pattern. It's a very sharply defined zone of involvement, which is distinctly in the lower abdomen. So it is not there in the rest of the spine, which characteristically shows that there has been some radiation. They have shown such cases where there is a sharp line of, even within the vertebra, sometimes there will be sharp line, and below that the signal will be fatty marrow, and above that it won't be there. So that's mostly post radiation. Here you see on T1 weighted images some hypo-intense lesions. So basically this is the marrow edema which you were seeing on the coronal images, but it would have been better if you could appreciate those on the sagittal images also, because those lesions which were hypo-intense on T1, they are bright here, signifying them as marrow edema. So, but in our routine practice, we of course we see the coronal images. What happens is on sagittal, we don't think of those sacral insufficiency fractures. As soon as coronal comes and we see the marrow edema, we know that sacral insufficiency fractures. So it was seen on sagittal also. If we pick up on that, it's even all the more better. But you told a lot about that case. It was very nice. This one. Okay, yeah, this one was a case of malignant intussusception. This also you told, you picked up the intussusception, you told the lead point was a malignant. So again, based on the chest radiograph, we knew that there are multiple lung lesions. So these are melanoma mets in this patient, and the obstruction is consequential to the melanoma mets in the bowel, leading to malignant intussusception. And of course, this patient will need a immediate surgical management, which also you mentioned that urgently inform. Very well done, Dr. Maria.
Thank you.
Now, Dr. Iman.
Yes.
Yeah, hello, Dr. Iman.
Hello. Work up for abdominal pain 55.
Yeah, you want me to scroll or you will scroll?
I can try.
Okay, just give me a second. I'll just see which case number is this. This is 21. Okay.
Okay.
You want to try?
Yes, I am trying.
Okay, okay. If there's a problem, I can help. Just let me know.
Okay, thank you. So I'm presented with a CT non-contrast of patient 55 with abdominal pain. This is non-contrast images. Okay, so I can see that in this non-contrast images, I can see that there is a left renal hyperdense lesion, hyperdense well-defined lesion. Bowel loops are not dilated, and para-aortic region is unremarkable. Liver, I can't see any abnormality in this. Can I proceed to the contrast?
Yes,
Other
yes.
than renal?
You can go through the entire series.
Okay. So this is arterial phase. I will just start from above. Okay, liver, spleen, pancreas are fine. And regarding the left renal cyst, the left renal cortical lesion, it's non-enhancing. Just I need to specifically assess. There is no evidence of septation within it, and it's not enhancing.
Are you sure?
Okay, there is right adnexal lesion also. Okay, cystic lesion. Let's. I will be. Okay. It's running. Okay. There is a small enhancing soft tissue nodule within it, within the cystic lesion. Otherwise, I can't see any enhancement.
So what do you think this is?
It's a cystic lesion, hyperdense in non-contrast, and showing small enhancing nodule in post-contrast. So I think it's hemorrhagic cyst. Yet I'm suspicious about this small enhancing nodule. So I may.
How do you
Sorry?
classify these? Is there any classification for these cysts?
Bosniak, this is, I think, Bosniak small enhancing soft tissue nodule. I think this is Bosniak 4.
Okay.
Or yes, 4.
So how do you manage this Bosniak type 4 cyst?
Bosniak type 4 cysts are suspicious cysts and need to be biopsied and refer to the renal urology team for biopsy and metastatic workup and excision.
Okay. So that's your next case. So patient had a surgery around 1 month back and has now presented with abdominal pain.
So I'm presented with CT of the abdomen and the pelvis. I can see that there is hyperdense, I think this is foreign body seen within the tissue of the liver, on the right lobe of the liver, and there is ascites, free fluid seen surrounding this. It's not free fluid, it's I think subcapsular fluid. I will go through the rest of the study. In the pelvis, there is area of fat stranding and mild wall thickening, but there is no no evidence of infection. Okay. Returning back to this, I think this may be misplaced. Part of catheter may be remained within the abdomen and causing hypodensity surrounding it, may be infected with subcapsular fluid and maybe
So
it
it has
and
a
infection.
long. So do you think it's a long structure? In how many sections could you see that? Can you scroll?
Sorry?
Can you scroll it? You said it's a porta catheter. That's what I heard.
Part of catheter or I don't no, it's I think it's part of
Part of
tube or
catheter.
catheter. Yes.
Part of catheter. Okay, okay, yeah. Okay, that is one possibility. Yeah, you can see the coronal images also.
Corona, okay. There is also subsegmental atelectasis seen within the or consolidation within the lung, and I can see that there is as if there is discontinuity of diaphragm.
The patient had surgery. The patient had surgery in the lower abdomen on the right side. If you can see there, there is some evidence of surgery in the right lower abdomen. Can you see?
Right lower abdomen.
Okay, I can tell you this patient had a history of appendicectomy 25 days back. So there is a small area which points towards surgery, previous surgery. There's a small connection here. Now, can you tell me what do you think that is?
This hyperdense, what is this hyperdense? This is can be maybe something from the surgical material, maybe. It's not a shape of gossipipoma, but maybe it's stone, maybe flipped appendiculis, maybe a flipped appendiculis, maybe also.
Okay, and then what happens?
And then there is infection surrounding it, and there is infection within the lower part of the right lung as well, and there is a fluid. So I think there is abscess formation surrounding it. So
what will you do next?
I will urgently inform the clinician about this, and the abscess, it's superficial. We can do ultrasound and drainage with a proper antibiotic therapy, but this actually needs to be excised surgically.
Okay.
So I
Can
think.
you please leave the control? Can you please leave the control? Yeah. So that's the next case.
Okay, work up for abdominal pain, 55 female.
This one you saw. Okay, sorry. Yeah, this one.
Okay, so I'm presented with AB radiograph of the right shoulder joint. And I can't see any abnormality, major abnormality in the imaging. By revising the ribs, I think there is just fading of the cortex of the scapula medially, but maybe this is projectional. Okay.
Patient has a history of some recent exertion. Yeah, with exertion in the shoulder. Exertion in the shoulder. Did some activity which caused exertion in the shoulder.
Exertion in the shoulder. Craniocapicular joints are fine.
Can you see anything?
I can't see anything. I'm not sure actually.
Okay.
I can see maybe there is a sclerosis inferior to the glenoid region, some sclerosis, and otherwise I can't see anything actually.
Okay. So what will you do
Um,
next?
Can I go? Can I see the other view if possible or helpful?
Yes.
Oh, it's posterior dislocation. Okay, so I can see that the humeral head is under the acromion. It's slightly displaced from the glenoid. So
Which view is this?
which view is this? This is oblique view.
Oblique view.
Yes.
Okay, what all views we do for shoulder commonly?
Axillary view, which is axial view, and frontal view and oblique view.
Any other views you know?
Lateral. I don't know. No.
Okay. So what are the causes of posterior shoulder dislocation?
Posterior shoulder dislocation. Okay. Usually, posterior shoulder dislocation is associated with a strong trauma, maybe in convulsions or maybe in electric shock.
Okay.
Or yes.
Can you tell me about some signs of posterior shoulder dislocation?
Yes, light bulb sign and light bulb sign and true sign. These are seen in frontal. So and
Okay.
otherwise, in other views, it's we will see that the humerus will be displaced posteriorly from the glenoid, away from the chest.
So if I go back to the frontal view, now can you appreciate any sign for posterior shoulder dislocation on this radiograph?
Yes, yes, I can see the light bulb sign, and I can see also the trough sign.
Come back to this. So that's the next case.
Okay, this is a radiograph of the pelvis, and I can see that there is a bulging fracture within the right anterior inferior iliac spine. So I will inform the clinician about this finding, and the patient should be in conservative management or away from exercise till recovery.
Which muscle attaches there?
Okay. Anterior superior, sorry, abductor femoris.
Which
No,
spine you
no,
said-
just okay. Sorry,
which spine you said this is? Anterior?
inferior,
Okay. So what attaches there?
rectus femoris.
Okay. So that's an avulsion fracture. Which age group you see avulsion fractures commonly?
Athletic adolescents.
Okay. So that's your next case.
Okay, so this is
ICU patient.
sorry,
That's an ICU patient. ICU film.
ICU patient. Okay, this is
ICU,
frontal.
ICU or ICU. Yeah.
Okay, so this is frontal radiograph of the chest, of the abdomen, sorry, and I can see there is tube. I think this is maybe stent, or I don't know what is this tube actually.
Okay.
And
What else?
there is multiple dilated bowel loops, not prominent bowel loops, and there is evidence of hepatomegaly. And the lower lungs shows opacification more on the right side, indicating pleural effusions. And
Patient is breathless. Is there any
breathless.
clue? Is there any clue for that on this radiograph?
Clue for what? Sorry,
Patient is breathless.
breathless.
Yeah.
This I'm not sure, but is this IVC stent?
You
I'm
can
not
ignore
sure.
this. You can ignore the stent.
Okay.
As of now, we'll discuss that later on. But do you see
Okay,
any findings?
I feel
Critical?
as if there is deep sulcus sign on the left side.
Okay.
Just
So what does that indicate?
pneumothorax.
Okay. So that was a chest X-ray for the same patient.
Okay, so there is evidence of left-sided pneumothorax. With the mild shift of the mediastinum to the right. So I think I need urgently inform the clinician about this for tube placement. And
Yeah, so patient is in the ICU. So you can, whom will you talk to?
to the ICU, to the referring to doctor or responsible doctor.
Okay.
Time is over.
Okay. So we'll start from this case only. Okay, we'll start from this case. Yeah. So this is a case of appendicolith. Basically, it's a dropped appendicolith. So a dropped appendicolith or retained appendicolith, you can also say that. And a patient had abdominal surgery 25 days back, as we already discussed. So because of that appendix surgery, the stone was dropped and it migrated superiorly and it lodged in the subphrenic space, and thereafter the patient developed infection there, because of which there was fever and pain in that region. So you correctly said that this patient would need surgical management. So the trick in this case was basically, I mean, they generally want us to think out of the box and think like, more like a detective sometimes, because they'll just simply say there was a surgery in the abdomen. They won't say appendix surgery, because when they say appendix surgery, unless we are not able to get to the point, because if they say that initially, then we'll very quickly come to appendicolith. So if we ourselves give that as a possibility, then that gets us a better score. So this was a case of dropped appendicolith with a small collection in the appendix bed. Also, you could see that as a clue if you could scroll that more, that there was a small collection in the appendix bed. This one is a small collection, but it's difficult to see in exam setting, because a small collection you can easily miss that. Only thing is, when we said about abdominal surgery and a stone, so appendix stone, we should think about that. That's why I kept that case. This was deep sulcus sign, very well identified. Only thing is, when you see a sign like that, it should come up quickly, not after the examiner asks so many questions, because the more questions they ask, the more points we lose. We lose actually. I mean, the more hints they give. What else? So if we are late in telling the main finding, we definitely lose points in that. This was ECMO tube. That's okay. If you are not able to tell that ECMO catheter or all that is fine. That's not a problem. Only thing which was expected in this case was this deep sulcus sign, which eventually you told. And this was the edge of the film kind of X-ray. Because when we are shown this KUB X-ray, we focus on the kidney region, we focus on the bowel, we focus on the bladder, we look for this abnormal. Then we're looking at hepatomegaly. We forget about this deep sulcus sign, because commonly we see this in supine and portable films. So when there is an ICU film, we do encounter such things in routine practice also. And this can even come up as a rapid reporting. Commonly it comes as a rapid reporting case, deep sulcus sign. This one you very well told, anti-iliac spine avulsion fracture. This was fine. So here I have a case to show. I especially got that. So there is one sign. I know that's subtle, but if they show a light bulb sign, then it will be very obvious. A light bulb sign, posterior shoulder dislocation, instantly you will tell. Here there is a loss of half moon overlap. That is one sign. If you see this, and I'll show you one. This half moon overlap. This is a normal half moon overlap. See this overlap. This is a normal overlap by the humeral head and the glenoid. Can you see this? This
Yes.
half moon, lenticular shape. Now you see our case. Where is that? This one. See, there is no overlap here. Can you see?
Yes. Yes.
Humeral head and glenoid, they are separate. You can't see the overlap. You want to see that again? See this? See, glenoid is coming behind the humeral head. So you see that lenticular shape overlap, right?
Yes.
On a frontal view. And here you don't see. It's a subtle sign. But if you appreciate that on a frontal view, and obviously you score high points if you can suspect that. Because if you see everything else normal, even the lung is normal, the bones are normal, everything, then there is something to be doing with the joint. And you have to think about the joint. And patient had recent exertion, I told you. And you don't see any fracture, you don't see anything related to that trauma, then you have to think of dislocation. And dislocation, then you have to think about the articulation. If you know these signs, that will help you. And then you can say something like, I'm not able to appreciate any distinct sign based on this radiogram. So I do, however, in my routine practice, I would see an orthogonal view to rule out dislocation. And this was a Y view. So this was a Y view which you do for shoulder. There's a posterior dislocation which is very well seen. Now when you tell posterior dislocation, they can ask you about the signs of posterior dislocation, which you can read up. They are, of course, once you told light bulb sign and trough sign, there's a rim sign, but sometimes they do ask in detail about the rim sign and trough sign, especially if that's seen in that particular case. But here they are not seen. And regarding this case, this was, you told Bosniak type forces, yeah, but once I prompted you, see, these things you should better not to miss, because once the examiner tells you and then you pick up, then of course the score would not be that great. If you do it on your own, then definitely it's better. So once you saw that, you told Bosniak type forces, which was absolutely fine. But then again, I had to ask you, what is that? I mean, how do you classify that? Once you see that hyperdense lesion on this, hyperdense contents on plane, so that has to be a cyst with some hemorrhagic contents, because it's not a mass, it's already a hyperdense, non-enhancing kind of a lesion, except that mural nodule which is enhancing. So this is a cyst with hyperdense contents with an enhancing mural nodule. So then you have to yourself tell that according to Bosniak staging, this will be a type 4 cyst. I mean, the examiner should not be asking you that, do you classify, how do you classify? I mean, that helps if you tell yourself. And of course, then you were right in telling urological management and everything you told. That was very nice. This one. Okay, this one. I think we've discussed your cases. Yeah, we have discussed your cases. Is there any case left? No, no, no. Okay, very, very well done, doctor.
Thank you.
Now, Dr. Ayaz.
Yes. Am I audible? Hello?
Yeah, you are audible, doctor. Okay. That's your first case.
Okay, this is the frontal chest radiograph of a skeletally immature patient. May I know the history, madam?
Just a chest, little bit chest discomfort. Child had some cough. It was just a routine which settled actually.
Okay, so going back to the lung fields, I'm not able to find any lesion in the lungs. The lung fields are clear. The costophrenic angles, these are normal. Seeing the heart size seems to be within the normal limit. The cardiomediastinal counter, the thymic shadow is little prominent. I can see some lucencies projecting on the side of the thymic shadow and causing some uplifting of the thymus. I don't see any free air under the diaphragm. Going back quickly to the bones, the vertebrae, these are fine. The ribs are fine. So I'm suspecting that the patient has pneumomediastinum. I'm not sure for the cause of the pneumomediastinum, but I will discuss the
sign of what is the sign of pneumomediastinum which you can see
this
on
is
this
say I think there is some raised thymus, the sale sign.
Okay, that, I can tell you that's a normal thymus, so you can ignore that.
Right.
Can you focus
right.
more on the bones?
Bones, okay. Okay, going back again, since I got some clue that I have to focus on the bones, there is some soft tissue swelling and some irregularity of the glenoid of the left scapula. Bones. Okay, I will go again. I will check systematically my bones. The ribs appear normal. The posterior ribs.
So you are seeing.
Okay. Yeah. There is actually, I think there are some fractures I can see on the scapula, and there is some.
No, those shadows are just projectional. Those shadows are just projectional. You can ignore them.
The patient is coming from ICU or patient is coming from OPD?
No, OPD patient.
OPD patient actually. So I'm suspecting that there is some rib fractures here on the left side. The second rib, and then again, if I come down, this area, I think there is some rib fractures, or the posterior ribs are fractured. I am concerned in this age group, and also suspicious scapular fracture. I am suspicious of.
I can tell you that there are no fractures in this case,
no
and patient has not presented acutely. Patient has not presented acutely.
Right.
There were some previous X-ray. There was one previous X-ray which was the same actually. There was no change.
Okay.
Yeah. So we can, in the interest of time, so that you see more cases, we'll just move on to the next case. No problem.
Okay.
We'll discuss this later on.
Pain and swelling in the both hands. 70 years old. Okay. So this is actually the frontal radiograph of both hands in 70 years old. I can see there are multiple abnormalities which are focused on the metacarpopharyngeal joints bilaterally and interpharyngeal joints also mainly on the right side. What I can see, there are erosions which is involving the articular surface, and there is bony proliferation, and the involvement is asymmetrical in comparison of both sides. And
you said bony proliferation.
Yes, this is
okay. Yes, please continue.
Erosions, bony erosions, and penicillin cup deformity. I'm suspecting that
Where is the pencil and cup deformity? Can you show me?
this one here.
Actually, I can't see your cursor.
Okay.
Maybe you have to click on that, or
Can you see now? This one is the first, actually the index finger, the between the interphalangeal joint.
interphalangeal joint. Okay. Okay, yeah, carry on, please. Please continue.
There is actually the marginal, there is marginal erosions. There is marginal erosions, and there is some overhanging edges also retrospectively if I see, and there is some soft tissue swelling.
Where do you see the overhanging edges?
Here in metacarpopharyngeal joints, this area.
Okay. Okay.
Actually, in my first impression, I was having the diagnosis of psoriasis, but reviewing.
So what other differentials come to your mind? And why do you think this is psoriasis, and in the first impression, or later on now, what do you think it is?
No, actually the erosions are.
So what are the areas of
actually I am also thinking about the
So where are the erosions based?
actually the erosions are, these are marginal erosions, marginal.
Okay, and which joints are involved predominantly?
The predominantly involvement is metacarpopharyngeal and interpharyngeal, actually the asymmetrical fashion.
Asymmetrical. And so what is the, yeah, you said something about bone proliferation. Do you still think there is bone proliferation?
No, there is some erosions actually. There is erosions, and I'm also having a suspicion that it is in Gulbing configuration, but that is erosive osteoarthritis that usually should involve the distal interpharyngeal joints.
Yeah, so you mentioned about erosive, you mentioned about
Erosion,
psoriatic, mentioned about marginal erosions and then overhanging edges. So that covers the entire spectrum. Can you just narrow down your differential? What is your
top differential with these findings will be gout actually. With the preserved joint spaces, I think the joint spaces are preserved.
What do you think about bone density in this case?
Bone density is maintained actually. Bone density is normal.
Okay. Can you see in the periarticular regions here, do you think bone density? Especially in the periarticular regions, what do you say about the bone density?
No, I want to take my statement back. This is the bone density is markedly reduced in the periarticular spaces, and this is symmetrical involvement, and there is some subluxation also.
Okay. So now what do you think this is?
This is now the rheumatoid. I'm thinking about the rheumatoid. If the bone density, especially the symmetrical, and
yeah. And you also mentioned marginal erosions, and you mentioned metacarpopharyngeal joints.
Yes, the involvement of the joint, the density, the erosions, this pattern can go with the rheumatoid. I want to take my statement back.
Okay. So we'll go to the next case. This one.
Okay, this is the frontal chest radiograph of a skeletally mature patient. May I know the history?
Patient,
Okay. Yes.
yeah, you want to know the history.
Yes. If it is available.
History will, patient just had a little bit of chest pain and some previous surgery.
Okay. So quickly reviewing the lung fields, actually the lung fields are clear. A patient has history of surgery.
Yes.
Okay. The
You can actually tell whatever you see on this radiograph.
actually the lung fields are clear. There is no focal lesion coming down. I can see there is well-rounded opacity seen in the right cardiophrenic angle. The diaphragm
Can you show
counter
me
is
opacity?
this one. This is rounded density.
Okay. Actually, I can't see cursor, but it's okay. Yeah,
If,
tell me.
it is right actually cardiophrenic angle.
Okay.
Both hyla are normal. The diaphragmatic shadow is normal. Postophrenic angle is normal. Going back to the bones, I can appreciate that the bone density is little increased, but I feel that this is projectional instead of real in pathological increase in density. The cardiomediastinal counter is normal. There is a line which I'm not sure this is bulging. This is going from this density.
So what do you think that line is? Why do you
This
think?
this could be a vessel, or if I'm thinking that the differential for this one, if it could be an hernia, it could be a Morgagni hernia. It could be an aneurysm from the right side of the heart.
Aneurysm? What is
Yes,
the density of this structure?
This is rounded box-like structure in the right cardiophrenic angle.
What is the density? If it is a vascular structure, how will it be? You said aneurysm.
Yeah, the vascularity actually is going with the blood vessels, but
you mean to say this you are talking about just the linear structure, or you're talking about this entire?
This is linear structure. The other
Just the
possible,
linear. Okay.
yeah, this linear. I'm not
I
sure
thought you were
about.
talking about this entire thing.
No.
What is
This linear.
Okay. Okay.
This is.
I told you the patient had previous surgery. So I can tell you that this appearance is because of previous surgery. So can you tell me what surgery would have happened and what problem would the patient would have had? Can you see any other sign of surgery on this radiograph?
Okay. The going for the breast shadow, actually, I am not able to see the breast.
Okay.
That's okay.
That's fine.
Okay, for the staples.
Okay, what we can do is we can go to the next case. We'll come back to this case. That's not a problem. You can see this case.
Okay, this is a frontal abdominopelvic radiograph of a skeletally mature patient.
I will give you the history. Patient has come with severe back pain.
Severe back pain. Okay, there is some rounded linear calcific density I can see in the lower abdomen, which is along the margin of a soft tissue, since the patient is having the severe abdominal pain, and this is in the region of aorta. I'm suspecting that the patient has aneurysmal dilatation of aorta. So I would like, I will contact immediately the referring clinician and will tell him for the findings. And I would like to know.
The patient would have had aneurysm. What would have caused severe pain at this point? What do you think?
Actually, if there may be some leaking from this.
Okay. So what will you do? You inform me.
Yeah, the patient should have a CT with intravenous contrast.
Okay, we have the CT, you can see that.
Yes, okay. So this is scrollable images?
Can you scroll or should I scroll for you?
No, I can ask. I
You
can
can?
ask.
Okay.
Yeah.
Yes, now you can scroll.
Okay, so based upon my suspicion for the X-ray, I can see there is aneurysmal dilatation, or there is, I will see once quickly the images before I comment. Going back, seeing the liver and spleen, I have seen some hypodense area in the liver, which seems to be something benign. Going back, the kidneys and the spleen, they are fine. My concern is for the aorta. There is aortic dissection, I can see. Having a
You
true
said
and the
dissection. You said
yes.
dissection. Can you show me the dissection, please?
No, I am trying to see that it is aneurysmal dilatation or it is dissection.
Okay.
I don't see up till now any dissecting flap.
So based on the radiograph, you told me you were suspecting aneurysmal dilatation with some leak that could have caused back pain.
Yes.
So you said you will look for the aneurysmal rupture of the aneurysm.
Yes, I
That's
am.
why we did the CT.
Yes. So there is some collection actually in the retroperitoneum.
So can you identify any point of leak?
Yeah,
And what is
this
collection?
one, this is the area which is hyperdense, and all this one along the left source margin.
Okay.
And I can see some enhancement. I'm going down.
Okay. So how are these patients managed?
So this is a leaking abdominal aneurysm. Actually, this I will contact the referring clinician, and patient need immediate referral to the vascular surgery and intervention radiology team for management.
Okay. So we'll go to the next.
Time is over.
Okay.
Okay,
So can you just leave
Dr. Noran, already, can I just take one already? I am depressed, very much depressed. If you will not, frankly, I will tell you, if you will not give me chance, I may drop my exam. I will go after 6 months. So this is your decision for me to take one more case.
Of course.
Otherwise, based upon, I will tell you, based upon my.
You told this case very well. This abdominal aortic aneurysm rupture, you told even on the radiograph, that was really nice. I mean, and very quickly you told.
Without any further discussion,
You want to see another case? No problem.
Yeah,
we'll
I may cancel my exam for 6 months. So please give me one more.
That's the next case.
Okay. So this is a bone window axial.
Yeah, you can see the bone window.
Okay. Actually, this is the sagittal.
Yeah.
Sagittal CT at the bone window of the patient, where I can see that there is an acute finding of separation between the L2, 3, 4, between L2 and no, sorry, 2, 3, 4, between L5 and L6 vertebra. I can see the ankylosis of the vertebrae and the syndesmophytes.
Okay. So what do you think this is?
This is, I think, the patient of ankylosing spondylitis. I would like to see the axial also, which has the fracture between L5 and L6. Just I want to see if there is any extension in the posterior elements. So this
You
is
can
an
see
acute
that.
find. This is an acute finding. If the patient is still here, I will check that because according to CT, the patient need a cervical fixation.
Okay.
So there is axial. Can I see the axial?
Yeah, please, you can see.
Yeah. So I will go quickly. I will come. Sorry. I'm not able to scroll. Can you scroll, madam? I am not able
Yes,
to
yes,
scroll.
please. I'll scroll.
No, I'm
Can you leave
scrolling.
the
It's
mouse?
not moving.
No problem. I'll scroll it for you. So basically, sagittal images are helpful, and what you have
There is
commented
actually
on-
distraction there. Okay, I will
Yeah,
explain the finding on
yeah.
sagittal.
You can
There
explain
is,
on sagittal. You already
yeah,
did that.
yeah, there is distraction between L5 and 6, 2, 3, 4, 5, and there is ankylosis and there is syndesmophytes. So I'm suspecting this patient, but I'm skull base also. I have concern. That is why I want to see the axial.
Okay. Skull base
That
is
there is
fine. I
at
can tell you.
base is
Skull
fine.
base.
Atlantoaxial joint is fine. So there
That's,
is
yeah.
actually distraction for fracture, causing distraction between the L5 and L6 vertebra. This is a non-complication in patient with ankylosing spondylitis. I will contact the referring clinician, and this is acute emergency. The patient need urgent orthopedic referral and fixation of the neck collar.
Okay, very nice. You want to see another case?
No, I think it's sufficient. The time.
It's sufficient. Okay. So that was very nice. That was a case of ankylosing spondylitis with fracture at this level, as you mentioned. So fracture is through the C5-6 with widening of the disc space because there are fusion at other levels. So it's very well seen that there is separation at this level, which is indicative of fracture. So there's intervertebral disc calcification and reduced intervertebral disc spaces at rest of the levels with ankylosed facet joints and oncovertebral joints. As you very well said that immediate neck immobilization needs to be done. One which was actually what they look for and what they want to hear, what you told. Another thing which you can mention is MRI to look for any cord injury. So that is also
the MRI should be done. Yes.
yeah. And neurosurgical referral, and you told immediate information and all those things. Yeah, that was bang on. And this one also you told very well on the radiograph, aneurysm and then followed by aneurysmal rupture, because I told you severe back pain, so you correlated it very well. So here you can see in the, I was asking you about the site of leak, it's fine. In the exam setting, it can happen that you can't identify the site of leaks and all, but very well, you can correlate that on radiograph. What was there on radiograph? There was this loss of psoas outline, or you can say the psoas outline appeared to be bulky here.
Right.
So that was the sign. And there was this calcification in outlining the aorta, which was indicative of abdominal aortic aneurysm because it was appearing widened. And this is the ruptured abdominal aortic aneurysm, which you can see, and that's the hematoma. So basically, this patient was managed interventionally after that, and they did this stenting, and they sealed the leak. Okay, so the patient was managed, as you said, referral to interventional team. And
Right.
this is a case of gastric pull-up surgery. See, this, yeah, see if you can see the radiograph, there are multiple rib defects here, if you can see. So this is, yeah, so what happens is the stomach is not seen here. You can see there's no stomach bubble seen. And so this is done for esophageal malignancy. So they remove the esophagus and they pull up the stomach and they artificially make esophagus through the stomach. So, and this is that part of the stomach, and here you have that air fluid level. That's why you are thinking this is a fluid which is causing it to appear opaque.
Yes. Now I got it.
Now you got it, right? So these kind of things you won't forget next time when you see, even if it is shown in the exam, you won't forget it. So in a way, it is good that you have seen few cases which you have not seen earlier. I think that's more helpful because that's going to help you in the exam. Now, if such a case you see in the exam, you will be happy that you saw it. So
Yes,
don't be sad about it. See, you told some of the classical cases like ruptured abdominal aortic aneurysm and cervical spine ankylosing spondylitis fracture, which was really very good. Now, these are the cases which are not very commonly we see, but if you see now, you will not forget it. That's for sure. So this is, in this case, I understand there are overlapping findings, but then you can be systematic. You can say bilateral symmetrical. First of all, it is symmetrical involvement. There can be more involvement of some intercarpal joints here, but then more overall, if you compare metacarpophalangeal joints, interphalangeal joints, all are involved symmetrically. It's more of metacarpophalangeal joints and intercarpal joints. Then there is periarticular osteopenia. There are marginal erosions. Periostitis, bony formation, new bone formation, that's more of a feature of psoriasis. So penicillin cup, I think maybe because of this was appearing a bit of penicillin cup, then this is not the typical one. These are more if you see marginal erosion and periarticular osteopenia. These are the characteristic things, and then intercarpal joint involvement, which you see in rheumatoid arthritis. So, and you can very well say differentials of psoriatic as well as erosive if you want to, and keep ruling out. Like psoriatic, you can say that's more of distal interphalangeal joint involvement, but here it is more of metacarpophalangeal and intercarpal joint. Here there is periarticular osteopenia, which is more in rheumatoid and not commonly seen in psoriatic. So I'm less likely thinking of that. Gout, I would think more in terms of overhanging edges, which I am not seeing here. And I would see soft tissue tophus in gout. Like that, you can tell also, and then you can exclude. Keep doing that alongside. That's not a problem because they can have overlapping features. This one's if you see it again, you don't see the clavicles.
Yes, cleidocranial dysostosis.
Yeah.
Yeah,
See,
yeah,
you know that.
Oh,
I mean,
I
it is
don't know.
not something we don't know.
No.
It's just that
No.
sometimes it happens when the first case is like that. Maybe that carries on in the other cases also. So see, now you will never miss a case with absent clavicles.
Yes. No, I see 2 days before in one sitting.
I think you were more focused. You got focused on this thymus, so maybe that was misleading.
Okay. Yes. No. Yes.
So this is a normal thymus. So this is not a pneumomediasis.
Yes. This is normal. No, I missed this one. This one.
So this is absent clavicle. So I mean that is those are the review areas like checking all the bones, and after you haven't found out anything, because sometimes in one go this thing doesn't come to us. Like in the previous case, Nail-patella syndrome, patella was absent. Here clavicle was absent. We are not used to looking for those things which are absent. Actually, we keep looking at those things which are present. So sometimes, which happens, which is quite normal thing. At that point of time, when you're not able to find anything, you can just recollecting. You can start recollecting. Okay, here what all bones we see. It might be a congenital thing because a small child like that. If it's a congenital, okay, let me see all the bones are there or not. Maybe like that you can think. And when you tell cleidocranial dysostosis, then the discussion can further go on Wormian. So they can ask about because this child had Wormian bones also.
Wormian bones. Yes.
Yeah. So that's okay, perfectly fine. I mean, it's sometimes autosomal dominant, most of the times rather. And they have large fontanelles. Those features can be discussed if you go further.
Right.
And one thing I would like to say, like you ask, can you tell me the history? Like, if you start like that, I would suggest a better way to start is first describe what you see.
Right.
Then when you describe what you see, then you can say, if this patient has fever, then I would be thinking in terms of infection. If this patient is having a history of weight loss and general debility, I would be thinking in terms of some malignancy, like that. Try to exclude, try to say yourself and try to exclude. When you say yourself, the examiner is going to help you. Like if that's a case of infection and you say, if this is a case of fever, I would, then the examiner will immediately say, yes, the patient has fever. You know, like that. Then they will
Right.
help you. But straight away, I would advise, don't ask what is the history.
Right, right.
Because if they have to tell you like that, they will tell you themselves. Like shortness of breath in a pulmonary embolism case, I told, so I purposefully told that. So rather, you were very good in the cervical spine. I didn't tell you that patient has presented acutely, but you said patient has acute presentation, which was very good actually. So don't get depressed. These are the two cases which when you see next time, you're not going to miss at all. Rest all
Right,
you
yeah.
told. Hope you feel
Thank you.
better now.
Yes.
Thank you, Dr. Aprajita. It was
Doctor.
very helpful and very kind of you for taking your time out and for such a
No
long
problem. My
and
pleasure.
healthy session. And for Dr. Ayaz, no need to get depressed. This thing can happen to all of us, and it happens to us as well. So please keep yourself calm. And as Dr. Aprajita mentioned, never ask about the history from the examiner unless they tell you. Please, this is my advice, because they will get annoyed, and that will not be good for you.
Yeah, you are right. But I don't know, Dr. Asad. The one of our colleague, Dr. Yasram, sent me some medicine also. I have started today. My problem is when I am seeing the Viva of other people. For example, when I see your Viva, the other candidates, I know, I feel I know all these cases. These are simple cases. And sometime when Dr. Aprajita was asking the question, I was I was knowing everything that these are simple.
Yeah, it happens.
But when my turn comes, I become flat.
As you mentioned about the medicine, and I can't go to